about the fact that she had scars all here, and she had apical scars from her pacemakers, and you completely miss it out. So make sure when you expose, you literally ask the patient to kindly take their shirt off. So what types of scars are you looking for in a cardiac examination? Was a couple already on there. So your midline stenotomy scar, what's that a sign of? Cabbage. So say coronary artery bypass graft. Some examiners don't really like acronyms, so try not to get into the habit of saying that. What else could it be a sign of?
Valve replacement?
Yeah, valve replacement. So how would you be able to tell the difference? Yeah, you can look at the legs, or you could hear their valves as well. So a good idea is when you expose the patient, before you go onto the chest and you're doing a general inspection of the chest, talking about scars, just give yourself 2 seconds just to see if you could hear a click, and they might have a metallic heart valve, and by then you already know the diagnosis, so you're laughing. There's also chest vein scars. They're really subtle and you could easily miss them. You've got scars further up for your pacemakers, and really feel out for them. If you think it's a pacemaker there, feel it, because they're not as big as they used to be. And then sometimes you could see heaves on some patients. I've not really seen any yet.
I've seen a few because I've had quite a few valvular patients, and it's usually around their left sternal edge, and you can just see their chest wall moving up and down.
Okay.
Don't forget about thoracotomy scars. Do you know where they are? So on the side of the chest goes round to the back.
So if you're unsure, you could ask them to sit forward and just quickly have a look. That's fine.
Yeah, don't forget to look at their back as well. Okay, so you've looked at their chest, then you palpate it. So what are you going to feel for first? Yeah, and where are you going to feel for the apex beat? Bit of space. And where? Yeah, okay. What else are you going to feel for apart from the apex beat? So what's a heave? Yeah, it's usually from right ventricular hypertrophy, and that's what I was talking about around the left sternal edge, because that's where the right ventricle sits under your rib cage. Oops. And does anyone know what a thrill is? Exactly, yeah. So you sort of feel vibration feeling under your fingers. It's not often that you'll feel one of those, and it's from turbulent blood flow. So you've already said what a heave might be a sign of. If your apex beat isn't where you think it should be, what are you going to do? Sorry? Can't hear you.
Try and find it.
Yeah, so where are you going to move? Yeah, round the side. So why might their apex beat be displaced? Yeah, hypertrophy. Good. So you felt the chest, and then you're going to have a listen. So we'll go through the sites where you want to listen, which I'm sure you already know. Timing, so listening to the heart sounds, and if you hear a murmur, timing it. Character of the murmur, if it goes anywhere else. And the specific move is to do to make any murmurs that you hear a little bit louder, so you can start to differentiate them from each other. So the site. What valve do you usually start with? I usually work in a systematic way, going across and down the chest. But what do you guys do? Do you all listen to the aortic first? Okay, so where are you listening for the aortic? Yeah. So it's around there. That's your aortic. What's this one? Pulmonary. Where's this one? Yeah. And you've got your mitral. So I'm sure you've all got that drilled into your heads already. Okay. As I said, you don't have to do it in that order. That's just the way that works for me. So, murmurs and heart sounds. I find it easiest to time with a pulse. So, does anyone know why you time with the pulse? Yeah, so the pulse is with systole, but which pulse are you going to use? The carotid, yeah, because it sits centrally, so obviously it's the nearest to the ventricle. If you feel a peripheral pulse, you can still time it, but it's a bit difficult because it's sort of the peripheral pulse is going to be sort of just after systole. So, what's heart sound 1? Which valves are closing for heart sound 1? Mitral and tricuspid. And heart sound 2? Yeah, exactly. So we'll start with aortic stenosis, just because it's in that area, and I think it's the easiest, usually loudest murmur to hear, and it's quite common, really. You will have another lecture that goes a lot more into valvular disease and why you get murmurs and things, but we'll just do a bit of an overview here for your exam, so what you're going to be listening for. So, aortic stenosis, can anyone describe it to me? Ejection systolic, yeah. And anything else about it? What else might you be able to hear? Where might you be able to hear it? In the carotids, yeah. So, just show you this picture. I always, when I'm trying to think about a murmur, I find it easiest to visualise the heart, sort of a mechanical way of looking at it. So your left ventricle pumps, pushes blood up through your aortic valve, and if that's narrowed, you get that harsh systolic murmur because it's when the ventricle is pushing blood through the valve. So, radiates up to your carotids, and I'll have a listen.
So can you hear the second heart sound? So in aortic stenosis, you should hear the second heart sound unless it's very severe, and then that gets, you won't be able to hear it.
Usually you can hear the second heart sound. You hear that harsh whoosh at the beginning through systole, and then you hear the second heart sound. Okay, next one, mitral regurgitation. I like talking about these two together because they're both in systole. So if you hear a systolic murmur, you're going to have to try and differentiate between the two of them in your exam. So what's the character of a mitral regurgitant murmur? Yeah, it's all the way through systole, and it's not as harsh sounding as ejection systolic because it's regurgitation, backflow through a valve, so it's sort of like a floppy valve rather than pushing all that blood through a really hard narrowed space. So I find it easiest again to look at the heart, the ventricle pumps, you get backflow through that mitral valve. So where's that murmur going to radiate to? Why does it radiate to your axilla? Exactly, because you've got blood flow going from your left ventricle into your left atrium, which is on the left hand side up at the top, so you can hear it in the axilla. So that's where it radiates to, that little yellow arrow, and have a listen. You all happy with that? Happy with the different way they sound?
So it's not as harsh, is it? And it's throughout the whole of systole.
Okay. So those are probably the two most common murmurs you'd get in your exam, and the hardest bit is deciding which one is which. Go on. Yeah, you can. It depends how bad the mitral regurg is.
Basically. It depends how severe it is. In your exam, you're not expected to know how severe the murmur is. So the idea is, in aortic stenosis, it's loudest in the aortic area, so that's your site. It should, depending upon how severe it is, it would radiate to the carotids. And when you're timing it with a pulse, it should be in systole, and really you should hear the second heart sound unless it's really bad. Okay.
Mitral regurg, you're going to hear it loudest over the mitral area or slightly higher up and hear it radiate to the axilla, and that's how you tell the difference between the two.
The idea is, when your aortic stenosis is so severe, you could hear it across the entire precordium, so you sometimes, with a lot of patients, you can't tell which one it is, but it's wherever you find it the loudest. You say, okay, it's loudest in this area, so it must be this, basically.
And to be honest, as I know we keep going on about your diagnoses and stuff because it's 5th year, but if you have a good stab at it, it'll be fine. If you don't get it right, it's just 1 point, it really doesn't matter. Okay, so that's aortic stenosis and mitral regurg. Next one, aortic regurg. So what part of the heart cycle is it in? Diastole. And why is that? Where's the blood going? Sorry, I can't hear you. Yeah, so it's already gone through the aortic valve, it's in the aorta, and it's falling back through the valve into the left ventricle. So there's your little heart, if you find it easier, like me, to just look at a heart to visualise it. So it's going back down through the aorta where it's coming from, backwards through the aortic valve into your left ventricle. So you might hear it loudest over the sort of tricuspid mitral area because it's going back into the left ventricle. And let's listen to it. Oops. Is it not working? Okay. Don't think that one's going to work, but if you go on the website, if you've got your hand out, type it in, have a listen. Basically, it's a diastolic murmur, so it's in the second bit of the heart sound, and it goes all the way through. Do you want me to copy and paste it?
Yeah, try and do it. It will not use, fine. It's okay.
Okay, mitral stenosis, the last one, also diastolic. Has anyone heard it before?
It's really difficult to hear a mitral stenosis because it's a diastolic murmur.
But as you can see from this picture, it's near the end of diastole, and it's because it's the blood flowing through your mitral valve, so it's when the heart's filling, so that's diastole. So you've got your narrowed mitral valve, blood's going from your left atrium into your left ventricle, but it's having to be pushed through a narrowed valve, so that's why you get the murmur. And where does it radiate to? Well, you'd hear it in the mitral region, but where does it go if it's really loud? Sorry? Yeah, laterally around the side. So that way. And does anyone know the specific manoeuvre that you might want to do to make it louder? Turn them on the side. And which side of the stethoscope are you going to listen with? Why? Exactly, it's a low pitched murmur, so you listen with the bell. Let's see if we can get this one to play. So you've got your first heart sound, which are those big lines, and then the diastolic murmur. I know that doesn't really sound like a heart, but it's the best we could find. Okay. So, just going over the manoeuvres a bit more, we've already talked about mitral stenosis. So you roll the patient over to the left, listen with the bell because it's low pitched. Does anyone know what you do with aortic regurgitation to try and make that louder? Yeah, and then what? Yeah, so you ask them to take a deep breath in, breathe out, and then hold it on expiration. Does anyone know why you do that? Why it works? Why it makes the murmur louder? Because what, sorry? Yeah, the blood is always flowing through the right side of the heart, but it's...
When you breathe in, it increases venous return to the right side of the heart, so the right side of the murmur is louder.
Exactly, that's why. The main thing is because if you breathe in, the venous return to the right side of the heart gets more, so that makes right-sided murmurs louder. So if you breathe out, you're reducing the venous return to your heart, making the left-sided murmurs louder, if that makes sense. Does anyone not understand that? Okay, cool. So, that's the manoeuvres that you want to do. And the last bits.
Okay, so end pieces. You've done a thorough examination of your murmurs and you think you know where it is. What else are you going to look for after that? The last things you're going to make sure you check in your cardiac examination. Yep, you're going to auscultate your lungs.
Why are you going to auscultate the lungs? What are you listening for?
Yeah.
Yeah, what does that sound like? What was that? Someone say fine inspiratory.
Fine inspiratory.
At the lung bases.
Okay. What else are you going to look for? Where?
Sacral or ankle.
Yeah, sacral ankle. If they've got ankle edema, then you want to say whether it's pitting or not, and then you want to follow it where it stops. So if they've got ankle edema up to their shins, then if they've got peripheral edema up to their shins, then you want to say where it is basically, and follow it upwards.
Yeah, so a good way to describe it, if you look at their feet, press on their foot, they've got pitting edema, go all the way up their shins. Just be careful though, because it kind of hurts when people press on edema to shins. And say the level where it goes up to. So bilateral pitting edema
At the level of.
up to the level of mid-shin, or up to the level of below the knee, or to mid-thigh, but you're not going to get someone in the exam with edema up to their mid-thighs.
Okay. What else are you going to? What else can you do? Check for. Yeah, you could do hepatic regular reflux. I haven't really done that in a cardiac examination because I've always really run out of time. So don't worry about running out of time and trying to fit everything in. What else are you going to do? So you've done your whole cardiac examination. You're going to back the patient and cover them up. Okay, and then wash your hands again. Okay. The last thing is summarising. So how will you summarise your examination? Think about what we talked about in your history, so it has to be quite concise.
Demographics.
Yeah, so you're going to say this is a 65-year-old lady that's presented with, now sometimes they don't have, before you go into your auscultation, it won't say this patient's presented with chest pain, do a thorough cardiac examination. It might not say that. So I've just put that in there just so, because it flows better. But if they've not, you could just say this patient is a 65-year-old lady. On cardiac examination, the positive findings were this, and this. So if there's any peripheral findings, then say them. If there isn't, don't say there isn't any Janeway lesions, there's no clubbing, there's no this, because you've already shown the examiner, you could see that. So it's like what Sarah said earlier when you're grouping things. So you could say there's on peripheral examination, there's no signs of infective endocarditis. The patient's pulse is regular at 75 beats per minute. On examination of the chest, she has a loud ejection systolic murmur in the aortic area, which radiates to the carotids. She has clear lung fields. These findings are inconsistent with aortic stenosis.
A relevant negative you could say there, so say if you think it's aortic stenosis, she's got ejection systolic murmur, radiates to the carotids, she's got peripheral edema, she doesn't have a slow rising pulse. So things that fit together in a group, so you need to have a reason of why you're telling the examiner something.
And then you want to say I would suggest doing further investigations, because the idea is now in your cardiac examination you've summarised and you want to try and find out what types of things you can do to see what the patient actually has. Okay, so this is when you have to say, I would now do bedside investigations, blood tests, so lab investigations, and then you want to talk about things like ECG, echoes. So I split all my investigations up as I would do them as an F1. So first thing you want to do is routine observations, don't you? So you'd say full set of routine observations. I'd want to do a 12-lead ECG, and then I'd then move on to doing laboratory investigations such as full blood count and say why. So you want to check for signs of anemia, urine electrolytes to see how the kidneys are. If they've got signs of any infective endocarditis, you could say you need to do some blood cultures. And then I'd move on to doing some imaging, such as a chest x-ray and an echocardiogram. It's really, really important in your cardiac examination that you mention ECG, because I'll give you one, and echocardiogram, because if they've got a murmur, then you want to know how severe it is, especially with things like aortic stenosis and pressure gradients and things like that. So you really need to mention it. And I think in my examination, there was something I was missing, and the examiner kept saying, and what else would you do, and what else would you do? And he was just looking for echo, basically. And then you've got your special tests, but don't worry about that. It's a good idea to know about there's other different types of tests that you can do, like cardiac MRIs and things.
Don't forget about simple things like bloods. If someone's anemic and they've got something like aortic stenosis, it's just going to exacerbate the symptoms of their aortic stenosis, so bloods are still important.
So common stations. In your OSCE, like we've been saying all the time, you're going to get stations which are the most common, basically. So these are the 4 ones that we can think of. Now, it doesn't mean that you won't get anything else, so don't rule out everything else and just revise these, but concentrate on these the most. So after everything we've talked about, quickly tell us what are the key findings of aortic stenosis from your peripheral and your central findings. slow rising pulse. Yep. Yep. What else? Okay, so slow rising pulse, narrow pulse pressure. So when you ask for, when you could say, you know, I'd check the blood pressure of this patient, you'd be able to see that there's a narrow pulse pressure. The severe the aortic stenosis is, the narrower the differences between your systolic and diastolic is. JVP, because if they've got valvular disease and it's significant enough, they could have pulmonary edema and they could have heart failure. LVH, because of, again, because of valvular disease, and with LVH you want to say if they've got a heaving apex beat or any thrills. And again, what you said, yeah, ejection systolic murmur, where it's loudest and whether it radiates to the carotids or not. Mitral regurg. Without looking at the handouts.
So what kind of murmur are you going to get? Yeah.
Okay.
Where's it going to be? Yeah.
Will you find anything in the pulse? Yeah, so if it's severe enough and if it's chronic, then they could have AF as well. Same with tricuspid regurg, but I don't know if you'll get tricuspid. So again, so work through it systematically. Think about your cardiac examination and what you'd find at each stage. So in the hands, you could possibly find atrial fibrillation. Their blood pressure usually is the same; it doesn't vary that much. JVP, again, element of heart failure, whether the apex beat is displaced or not, whether they've got heaves, and then again, central examination. Don't forget to check for scars and things like that as well. You want to, as you mentioned, pansystolic murmur, whether it radiates or not. I think everybody tends to think mitral regurg always radiates to the axilla. It doesn't always, so make sure you check that. And then again, if they've got signs of infective endocarditis, because that mitral valve is the most common one anyway.
It's not a common thing to have infective endocarditis, but you've just got to think about reasons why this person might have mitral regurg. I mean, infective endocarditis is one of the causes. Does anyone know what else causes mitral regurg?
Rheumatic
fever, that predisposes them to getting endocarditis. That's why that's important.
So it's like you were saying, one of you guys was saying earlier about, well, how am I supposed to tell the difference between mitral regurg or aortic? The idea is, what you want to show the examiner is you could put together your peripheral findings with your central as well. So if they've got a collapsing pulse, then you know that the murmur you're listening to isn't really mitral regurg. It's most likely they've got aortic regurg, because that's something that fits with the rest of your findings. So try and piece it all together.
The other ththing that can cause mitral regurg is having an MI, because you know the little Purkinje fibres? No, not Purkinje fibres. What are those things called? The papillary muscles, that's the one. When you've had an MI, the muscle dies and your papillary muscle can rupture, and that causes your mitral valve to prolapse and you get a regurgitant murmur, so that's just another cause of it.
Okay. So, have you guys got any questions about your... I know that was a really quick run through, but do you have any questions about your cardiac exam auscultation? Anything? You have no... Okay. So...
If you've got any questions at the end, feel free to come forwards and ask if you don't want to ask them now. So, can we have 2 volunteers?
So we've got a station that is very similar to what you can get in your OSCE. This is the type of thing we had. So, and bearing in mind, you'll all be at different centres for your OSCE exam. So if your friend has had aortic stenosis and they think they've got aortic stenosis, the examination you had won't necessarily be aortic stenosis. It might be something else completely different. Everyone will have different patients that have different signs. They won't necessarily be the same. So don't panic if you don't have the same thing as your friend.
Does anyone want to have a go? We're going to walk you and talk you through it. You're not going to have to do it in front of everyone on your own.
If you could do it in front of 50 people, you could do it in front of one examiner. No? Nobody wants to be the patient?
No, you don't have to be the examiner, you can just be the patient.
Does anybody want to be the patient?
I'll be patient.
Yay!
Thanks.
So
Anyone
come on,
want to examine?
Yeah, does anybody want to examine her?
This beautiful young lady.
Nobody wants to
Don't
have
mind
to go
being
and do a
recorded.
cardiac examination.
The
Mind
more you
being
go
recorded.
through it, the better you'll be for your exam. Just honestly, it's practice, practice, practice. Everyone's avoiding eye contact.
You're gonna do it.
Yeah. Okay, so you want to push through it. You're not timing it, are you? No, you're not going to do it in 6 minutes. You're going to talk through it.
Okay, do it. Okay, so we're going to go through the examination.
Can't examine your friends. She was a patient.
Okay, so Sarah's going to be the student.
Do it.
Are you going to do it?
I'll do it. It might be quite good for one of you guys to do it though. We can watch like the picture perfect.
Yeah, I'm not going
Okay.
to do it in 6 minutes. I haven't done that since my OSCE, but we'll have a go
Okay.
if you want.
So bearing in mind she's normal, so there won't be that many findings obviously, but Sarah will go through it exactly how you need to do it in OSCE, and I'll be the examiner.
Make sure I don't miss anything out.
No, yeah, if there's anything I'll add.
Because I'm under pressure now.
Okay,
Alright, okay, so walking to the exam station.
I'm your examiner.
Hi, my name's Sarah. I'm one of the 5th year medical students. Washing my hands. Can I just confirm your name and date of birth?
Alex Button, 21
That's great. I'm just going to do a cardiovascular examination. It'll involve you looking at your hands and your chest and having a listen. Is that alright? Okay. So on general inspection, I can't see any GTM, oxygen masks or drips. The patient looks comfortable at rest. Can I take a look at your hands, please? Okay, warm and well perfused. Capillary refills less than 2. No peripheral stigmata of endocarditis. No anemia. I'll time the pulse, ideally for a minute. So time it for about 30 seconds. Do the respiratory rate at the same time. There's no radial delay. Ideally, I'd like to take a blood pressure at this point. Have you got any pain in your shoulder? No collapsing pulse. Could you just look up towards the ceiling for me? I'm going to pull your eyelids down. No anemia. No sample asthma. Can you put your tongue out for me? And lift it up to the roof of your mouth. No central cyanosis and good dentition. Thank you. So, just going to feel your neck. Good fine carotid pulse. And can you rest your head back for me? Should be a bit lower down.
Don't
Look
forget to
towards
lower
the
that.
left. So, can't see a JVP, which is normal. Obviously, I would have described the pulse and not missed that out. So, taking a look at the chest, I want to expose the patient adequately, so I'm not going to do that now, don't worry. No obvious scars. I'd like to look at the back as well. There's no visible heave, so I've had a look. I'm going to feel your chest. Is that all right?
Yeah, that's fine. Just keep checking with the patient like Sarah's doing. Don't worry about running out of time all the time. So what you tend to do is get really nervous in your OSCE exam, think about the time all the time, and then forget that that's a real person over there, and you start moving things around. If you can involve the patient. You could say, can you turn your hands over for me? You know, can you look up, like Sarah was saying, you know, if they've got glasses on, can you take your glasses off for me? I'm just going to have a look in your eyes, things like that. Sorry, carry on.
Did you see where I felt there? So you're feeling over the aortic and the pulmonary, over the left sternal edge, and under here where the mitral is, and feel for the apex beat. So there's no palpable heaves, I can't feel any thrills. Okay? I'm going to listen.
Sarah's now listening in the aortic area. So in your final year, you're not expected to say, I'm now listening in the second intercostal space, right sternal edge for the aortic valve. There is no murmurs. You're not expected to say that, but if you're showing that you're counting where the intercostal space is and you're listening in the correct areas,
Can you roll over to your left?
it'll be fine. Your examiner will be watching you. Because really what you're trying to do is try and hear out where this murmur is, and if you're talking at the same time, you won't be able to hear it.
Okay, can you sit forwards for me? Take a deep breath in, and breathe out, and hold it.
So can you see that Sarah's listening in the aortic area like that? I think like what a lot of students get confused with is when they're listening into the tricuspid area, And they stop there, tell the patient to lean forward, take a deep breath in, breathe out, and then they say they're listening for aortic regurg. I mean, I've seen that quite a lot in cardiology with lots of students. So you do that in the aortic region, and in the tricuspid region, you just listen in the fourth intercostal space. That's it. You don't need to tell them to sit forward or anything.
Okay. Also, to make it easier to listen in the carotids, I usually ask the patient to take a deep breath in and hold it, so you don't hear the breath sounds. Take a deep breath in for me, and hold it. Okay, breathe away. While the patient's in this position, this is one basis, deep breath in, and out, and in, and out. Check the stable edema. There isn't any. Sit yourself back again. And there's no peripheral edema. And then that's the end of it, and at that point you probably present your findings to the examiner. So this is a 20-odd-year-old lady who has an irregular pulse, which feels like AF. She has an ejection systolic murmur in the aortic region, which radiates up to the carotids. She doesn't have any peripheral signs of edema. This finding suggests that she has AF and aortic stenosis, so let's do some bloods, ECG, echocardiogram.
Okay, so that so far, including us talking in between, was about 5 minutes. So that was really quick. Now, this patient's normal, so your patient's going to have a lot of potentially going to have a lot of findings. So the idea is quickly go through the arms and the face and the neck. Really concentrate on the chest. So you want to spend most of your time on the chest to try and figure out where this murmur is. Because if they've got a really good murmur, then you've really cracked it, and then you know exactly what types of investigations you're going to ask for, and you'll be more confident in presenting your findings. The worst thing is when you're really, really unsure, and then you come to presenting your findings and you say, oh, well, I think it's aortic stenosis, but then maybe it could be this. If you don't know what murmur is, don't say it. Say it's an ejection systolic murmur. It's loudest in this area. With these findings, it's likely that it is this. So you're confident that you've come up with a conclusion. So then, after the patient, the student has presented, I would then, as the examiner, say, okay, so you want to do an ECG. Can you tell me what you think of this ECG?
Any ideas? So what's the most obvious thing you can see on there? ST elevation. So what leads is it in? So what area of the heart is that? Sorry?
Anterior.
Yeah.
Yeah,
Anterior. So what else can you see on there as well? Anything else?
Left ventricular deviation.
Yeah, I'd buy that. Anything else? Well, yeah, do you know what?
Yeah.
Yeah. So you've got ST depression in 2, 3 and AVF, which are the inferior leads, which are reciprocal changes for an anterior, and mild ST elevation changes in the anterior leads.
So remember when you third year when you had an ECG station, you probably went through the demographics. This is a ECG of so-and-so at this time in LGI or GMEs or wherever. They have a rate of this, the rhythm of this, it's in sinus rhythm. You're not expected to do all of that in your final year OSCE. The idea is, it's the last thing you're going to be doing before you run out of time. So I would do, the way you do it really is, this is an ECG of this lady. The most obvious abnormality on the ECG is this patient has an anterior ST elevation because she has ST elevation in these leads. She also has reciprocal changes in the inferior leads and element of LVH. Now I would go in a systematic order at looking at the whole ECG.
Just do that if you've got time. The main thing they want you to spot is the diagnosis.
The diagnosis, yeah. So don't worry if you can't even go through everything.
So,
I was asked on that, is there left axis deviation or not?
There is. Yeah.
So for your auscultation, usually I'd say spend about 6 minutes on examining the patient, because then you've got 2 minutes left for your summary and for them to show you any of the things like the ECG or chest x-ray that you can interpret something. So make sure you leave enough time at the end to try and figure out what's going on with those pictures.
So, on summary, just to quickly summarise, so we've gone through focus history, how you should really do it in your final year, likely diagnoses that you could come up with, so aortic stenosis, mitral regurg, AF, heart failure. Kind of examination for your finals, you really want to do a good summary, concise, with investigations in view of what your findings are, and then how you summarise at the end. We've gone through that, and then what you would possibly expect from your OSCE by doing a practical run through. Do you guys have any questions? And it could be about anything really. Is there anything you're worried about in cardiology generally for your OSCE? Because you will be getting lectures on the theory behind it. So you'll be getting lectures on arrhythmias and valvular disease and things like that.
We've got a lecture on ACS and heart failure to come as well, so there's a lot more on the theory side of things, but this is your chance to ask about the OSCE.